Hey fellow lab rats, this is Rebecca from the Lab Rat YouTube channel. This video we are going to be talking about enzymes and cardiac markers as a part of our clinical chemistry lecture series. Alrighty, let's get started. So what are enzymes? So these are substances that are produced in the body that act as a catalyst to bring about a specific biochemical reaction. And when I say catalyst, I mean they speed up that biochemical reaction. So we can use enzymes as clinical laboratory professionals to determine tissue damage. Elevations of certain intercellular enzyme levels in the blood indicate a destruction of the specific tissues in which these enzymes are located. When we're discussing enzymes, the terms active site and allosteric site come up. An active site is the region of a particular enzyme where substrate molecules bind and then catalyze the biochemical reaction, and this results in the production of specific products. The allosteric site of an enzyme is where it allows either an activator or inhibitor molecule to bind to the enzyme and either activate or inhibit that enzyme's activity. Both the active site and the allosteric sites help to facilitate the enzyme's binding and subsequent biochemical reactions. Now, the term isoenzyme also comes up with discussing enzymes. And isoenzymes are molecules that catalyze the same biochemical reaction as the enzyme, but are different from that enzyme either chemically, physically, or immunologically. So in the clinical laboratory, we can test for different enzymes and some of their isoenzymes as well. So there are a number of factors that influence the action of enzymes. So these include the reaction conditions like the pH and the temperature of where the reaction is occurring at. Each enzyme has a preferred pH range. If the pH where the reaction is occurring is increased or decreased beyond this range, the enzyme activity will slow down. Generally speaking, an increase of temperature will increase the rate of the reaction as well. Enzymes will work best if there is plenty of substrate. As the concentration of the substrate increases, so does the rate of enzyme activity. However, the rate of enzyme activity does not increase forever. Once all the substrate is bound, the reaction will not speed up since there is nothing for the enzyme to bind to. Increasing substrate concentration also increases the rate of the reaction to a certain point. Once all the enzymes have bound, any substrate increase will have no effect on the rate of the reaction, as the available enzymes will be saturated and working at their maximum rate. The presence of cofactors affects the activity of the enzyme. So these are helper molecules that help to assist the enzyme speed up that reaction. And then lastly, inhibitors are those molecules that affect the activity of an enzyme. So these are molecules that either temporarily or permanently interact with the enzyme to reduce the rate of the enzyme's catalyzed reaction. So we'll now briefly discuss enzyme kinetics with first order kinetics and zero order kinetics. So chemical kinetics help to describe the rate of enzyme catalyzed reactions. The main difference between first order kinetics and zero order kinetics is that in first order kinetics, the rate of the reaction depends on the concentration of one reactant. In zero order kinetics, the rate of the enzyme catalyzed reaction does not depend on the concentration of the reactants. Creatine kinase, or CK, is an enzyme that is distributed within the body's tissues. The highest concentration of creatine kinase is within the skeletal muscle, the muscles of the heart, and the tissue of the brain. CK levels are often elevated in diseases or disorders of the cardiac and skeletal muscle. It can also be elevated with the development of central nervous system disorders. Increased levels of total CK are good indicators of these disorders, however, are not specific indicators for one disease or problem. So what I mean when I say not specific for a disease means that we cannot immediately diagnose or know exactly what is going on with a patient when their CK is elevated. We only just have, a general idea of what's going on. There are some analytes that we can pinpoint exactly what tissue is having a problem. So for example, troponin is specific for the heart, and we'll talk about troponin here in a bit here. So total CK doesn't pinpoint to one specific thing. It can be a few things that are going on with the patient. So either an issue with the skeletal muscle, the brain, or the heart. So it's not specific or one specific thing. So for a more specific indicator, total CK is often divided into separate, more specific tests of the CK isoenzymes. There are 3 clinically significant CK isoenzymes, and these are CK1, which is also called CKBB, CK2, which is also called CKMB, and CK3, which is also called CKMM. CKBB is found primarily in the brain tissue. Elevations of this isoenzyme can occur when a patient has experienced a stroke, has had a seizure, or has experienced another cerebral injury. CKMB is found primarily in the heart and skeletal muscle. This isoenzyme can be elevated after an acute myocardial infarction, which is a heart attack, myocardial injury, and also other cardiac conditions. CKMM is found primarily within the skeletal muscle tissue. This isoenzyme can be elevated after an injury to the skeletal muscle. Now, the normal reference range for total CK for males is around 15 to 160 units per liter, and for females is 15 to 103 units per liter. So men usually have a higher level of CK due to an increased muscle mass in comparison to women. So in acute myocardial infarctions, or AMI, so this is the medical name for a heart attack, a patient's total CK levels will rise within 6 hours after that heart attack, and it gets to its highest amount within the body 24 hours post that heart attack. Within 3 days of the heart attack, the total CK will fall and reach normal levels again. Duchenne's muscular dystrophy is a genetic disease where patients experience progressive muscle degeneration and weakness. So this is affecting the skeletal muscles. So total CK will be elevated in these patients as well. Crush injuries, so these are injuries where the muscles are crushed. This makes sense that total CK would be elevated in these instances because, of course, it is in the skeletal muscles. And again, CK is in the brain, so issues that affect brain tissue like a stroke or a seizure will also cause elevations in total CK. The most commonly used method for the measurement of total creatine kinase in the laboratory is the reference method for this assay called the Oliver and Rosalke method. So you don't need to know the inner working details of this reaction, just that this is the reference method for total CK testing. But in short, a sample that contains total CK in it is reacted with a reagent that produces a change in absorbance, and that change of absorbance is measured using a spectrophotometer, and which this change of absorbance is proportional to the amount of total CK present within the sample. So specifically, the NADH absorbance is measured at 340 nanometers on that spectrophotometer. So the Oliver and Rosalke method is for measuring total CK. And total CK is performed all the time in hospital laboratories. Usually only reference laboratories or really large hospital laboratories do the testing of the CK isoenzymes. And this can be performed using gel electrophoresis or anion exchange column chromatography. So this is a really tedious and time-consuming procedure that separates molecules based on their net surface charges. Immunoinhibition can also be used for quantification of CK isoenzymes. So in this method, it uses an antibody that is specific for the M subunit. So this antibody binds the M subunit, making it inactivated. So all the CKMM isoenzyme is going to be totally inactivated because all it contains are those M subunits. CKMB is going to be partially inactivated because there's one M subunit and the other one is B. And then CKBB is not going to be affected at all by this immunoinhibition because it doesn't have an M subunit to be inactivated. Immunoassay methods can also be used for CK isoenzymes. So this measures the amount of enzyme present and not the activity of the enzyme. And like I said again, CK isoenzymes are usually not routinely performed in a regular hospital laboratory, mainly just due to the test not being ordered frequently enough to outweigh the cost the laboratory is required to keep up with quality controls and reagents for the testing. So usually doctors will order just total CK, and if they think that a CK isoenzyme is indicated. If the hospital lab is big enough, they'll perform it there. If not, it gets sent out to a reference laboratory. Myoglobin is a globular protein that binds oxygen in the striated muscles and muscles of the heart. For diagnosis of an AMI, which again is a heart attack, myoglobin levels can be used in conjunction with troponin levels. So again, we'll talk about troponin here in a moment. Myoglobin is the first cardiac marker to rise after an AMI, rising 1 to 3 hours after the initial damage. Around 18 to 24 hours post-AMI, myoglobin levels return to normal. So even though it is the first cardiac marker to rise after a heart attack, it's not commonly used for the detection of a heart attack when a patient comes in with chest pain. And the reason for that is that it's not as specific as other markers like troponin. So myoglobin is in the muscle of the heart, and it is also located in other striated muscles. So imagine going into the hospital with chest pain and you get blood work done and the doctor comes in and says, well, you might be having a heart attack, but we're not 100% sure. So like for something so serious, this is really just unacceptable, right? So this is why we want to use a more specific test for acute myocardial infarctions and not just myoglobin. And so this test, the test that is most specific for a heart attack is on the next slide. All right, so here it is. So troponin. So troponin is a structural protein that is elevated in case of myocardial injury. So troponin is the most commonly used cardiac marker in the clinical laboratory because of its specificity. After an acute myocardial infarction, troponin levels rise in about 3 to 6 hours and stay elevated in the blood up to 2 weeks. Clinical laboratories can run either a troponin T or a troponin I test. So the troponin I test is actually the most specific as this protein is only located within the myocardium, but both are considered very, very specific for myocardial injury. Homocysteine is an amino acid that serves as an intermediate in the synthesis or production of cysteine or metabolism of methionine. So this metabolism requires the vitamins B6, B12, and folate. So if a patient has a deficiency of these particular vitamins, it can cause an elevation of homocysteine, which then can lead to a damage of the endothelium in the blood vessels. So a homocysteine level in the blood greater than 10 is considered a risk factor for cardiovascular disease in patients. C-reactive protein, or CRP, is what we call an acute phase reactant. So remember, acute phase reactant is a marker that increases in general inflammation or damage to tissues. It's used in the clinical laboratory as a predictor of future events, so either atherosclerosis or thrombosis. So atherosclerosis is a disease of the arteries where plaques and fatty material adhere to the inner wall of the arteries. And thrombosis is the fancy term for a blood clot. So CRP is considered, it's not considered a specific test, but more of a general indicator of inflammation within the body. Brain natriuretic peptide, or BNP, is a peptide that is stored primarily in the left ventricle of the myocardium in the heart. The peptide is released from the heart when there is volume overload by the heart not being able to pump efficiently. So BNP is most often used as a marker for congestive heart failure. Just to give you a tip here, if somebody calls into the laboratory, doctor, nurse, or whomever, and orders a BNP over the phone, make sure that make sure it's the right test. So BMP, which stands for a basic metabolic panel, sounds very similar to BNP, which is this B-type peptide. So make sure to clarify what test they're talking about and don't assume. Just as a tidbit for you. So lactate dehydrogenase, or LD or LDH, is an enzyme with tissue sources in the heart, liver, pancreas, red blood cells, skeletal muscle, and the lung. There are 5 clinically significant isoenzymes of LD, and these are LD1, or HHHH, and LD2, which is also called HHHM, and these are located in the heart and the red blood cells. LD3, which is also called HHMM, is located in the lung, spleen, and the pancreas. LD4, which is also called HMMM, which is located in the liver, and LD5, which is, you guessed it, MMMM, and this is located in the skeletal muscle. So like with CK isoenzymes, the isoenzymes of LD are not commonly performed at a regular hospital laboratory. So hospital laboratories will likely only run total LD tests, and if the physician wants a specific isoenzyme tested, these will be sent out to a reference laboratory to be performed. The normal reference range for LD is 100 to 225 units per liter. Because of the presence of this enzyme in multiple tissues, an elevation of LD in the blood can occur in multiple disorders. An increase of LD may occur in hemolytic anemia. This is a disorder where red blood cells are destroyed faster than they can be made in the body. And LD, of course, is present in the red blood cells. So if those red blood cells are lysing, it's going to be going to release more LD into the plasma. Also, in an AMI or heart attack, LD levels can be elevated. Skeletal muscle involvement or destruction can cause a total increase in LD. As well as hepatic injury or hepatic inflammation. So this is injury to the liver or inflammation of the liver. A malignancy in any of these tissue sources of LD can cause an increase in the plasma, and also pneumonia and pulmonary embolism can cause an increase. And pulmonary embolism is when a blood clot occurs in an artery in the lungs and blocks blood flow. Aspartate aminotransferase, or AST, it's also called SGOT in some laboratories. So this is an enzyme that helps to transfer an amino group between the amino acid aspartate and keto acids. AST is located in multiple tissue sources, including skeletal muscle, liver, kidney, and the heart. The reference range for AST in the blood is 5 to 30 units per liter. So in the clinical laboratory, elevated AST levels are used for detecting hepatic disorders and issues with skeletal muscle. So it's mainly considered a liver function test. AST can also be elevated in patients that have suffered an AMI, which, reminder, is acute myocardial infarction, which is a heart attack. Alanine aminotransferase, or ALT, or also called SGPT in certain laboratories, is also a transferase enzyme similar to AST. The highest concentration of ALT in the body is within the liver. It is the most specific liver enzyme currently available in the clinical lab because it is in the liver hepatocytes, so the cells of the liver. The normal reference range for ALT is 6 to 37 units per liter. Elevations of this enzyme are associated with hepatocellular disorders, so disorders of the liver. Alkaline phosphatase, or ALP, is an enzyme that is present in various tissues throughout the human body. The highest concentrations of ALP are within the liver, bone, intestine, kidney, and placenta. Elevations of ALP often occur in hepatic disorders and disorders of the bone. It can be increased if the patient has rickets, which is a disease in children caused by a vitamin D deficiency, and this is characterized by a distortion of the bones, resulting in bowed legs. So since ALP is in the bones, if a patient has a bone fracture or bone cancer, ALP will be elevated as well. So the normal reference range for ALP in the blood is 30 to 90 units per liter, with children having 2 to 3 times higher level of adults due to them developing bones. Gamma-glutamyltransferase, or GGT, is an enzyme located mainly in the kidney, liver, and pancreas. It's most commonly used in clinical laboratories for the detection of hepatobiliary disorders. So these are disorders of the liver and the bile ducts. Elevated levels of GGT may also occur in the blood of patients who chronically abuse alcohol. The normal reference range for GGT for males is 6 to 45 units per liter, and for females 5 to 30 units per liter. Acid phosphatase, or ACP, is an enzyme that is present in the prostate gland, semen, bone, liver, kidney, red blood cells, white blood cells, and also in platelets. The highest concentrations of ACP are in the prostate gland and is used in the clinical laboratory for aiding the diagnosis of prostate cancers, and it also can be used in rape documentation. Prostate-specific antigen, or PSA, is a test that is used primarily to screen for prostate cancer. PSA is a protein that is produced by both cancerous and non-cancerous tissue in the prostate gland. And because it is produced by malignant and benign prostate epithelial cells, if the PSA is elevated, it does not automatically mean that the patient has prostate cancer. It can also be a benign prostate issue. The laboratory has two different PSA tests: a free PSA, which measures the unbound PSA, meaning PSA that's not bound to any other proteins and just kind of circulates freely in the blood, and total PSA, which measures both the free PSA and those that are complex to a protein. So most PSA is complex to a protein in the bloodstream. Estimated about 70 to 80% of all of it is complex to a protein. So a free PSA to total PSA ratio can be used to help the physician determine the relative risk of prostate cancer for the patient. So the lower the ratio is, the higher risk of a malignancy of the prostate gland. Amylase is an enzyme that is responsible for breaking down starch. It's present within the salivary glands and the pancreas. Amylase is used within the clinical laboratory for the diagnosis of acute pancreatitis, which is an inflammation of the pancreas organ. This enzyme can also be present in patients with mumps, kidney failure, and several types of cancers. So mumps, you can see on this picture on the right-hand side of the slide, this is a child that has mumps. This is a contagious viral illness that causes a swelling of the salivary glands, and also usually patients have a fever with it. So the normal reference range for amylase is around 25 to 103 units per liter. Lipase is an enzyme found within the pancreas. Like the enzyme amylase, lipase is used for the diagnosis of acute pancreatitis. Because this enzyme is only located within the pancreas, lipase is known for being a more specific marker of pancreatitis. So the normal reference range for lipase is 0 to 0.1 units per milliliter in a normal patient. Alrighty, so that concludes our lecture on enzymes and cardiac markers. If you like this video, please make sure to like it and also subscribe to my channel for more educational laboratory content. Alright, until next time.